what we found that the oral contraceptive, the scheduling of oral contraceptive with gene-rich antagonist have ended in 78 and 90% retrieval performed on 5 days of the weekdays for the gene-rich antagonist, while in the agonist, it was like 90%. The differences between these protocols were not statistically significant. However, in other protocols that gene-rich antagonist was manipulated or used for scheduling the intrauterine insemination for applying the weekend-free protocols, the authors found that there was a statistically different in the days of stimulation in the weekend protocol, and furthermore, they found that the level of the estradiol was significantly lower in those patients being treated with the gene-rich antagonist. And however, when we go to a prospective study performed by from other groups, which included 413 patients undergoing ovarian stimulation based upon gene-rich antagonist co-treatment, prolongation of the follicular phase, meaning delaying the administration of HCG for 2 days after the point at which at least 3 follicles have been for 17 millimeters, this study found that this approach resulted in a lower probability of ongoing pregnancy per oocyte retrieval and per embryo transfer compared with no delay. So nowadays, in the era of evidence-based medicine, you can't make conclusion based upon one or other cycles. In order to make such conclusion, we have the evidence pyramid in which you should look into either if you have prospective studies, or if you don't have these studies, you should analyze or look into the meta-analysis which have been performed in this subject. One of these meta-analysis or one of these investigation was described recently by the group of Greisinger, in which they looked into the effect, or they looked at the articles that have been published in the literature. And like you know, in such kind of studies, the meta-analysis, you may begin with a bunch of follicles, and you then end up with a small articles which may have fit the criteria that you're looking for. And indeed, in this meta-analysis, they ended up with 4 articles which meet the criteria that they have decided. And what they found from these 4 randomized controlled trials, that oral contraceptive pretreatment was associated with increased total gonadotrophin dose and duration of stimulation, which we have learned before. But there was a trend towards a reduction in the ongoing pregnancy rate among these patients who've been treated with this protocol. So this is a very important point that we should take and consider once we adopt this kind of protocol. Recently, an article been published by in the Human Reproduction by the Australian group Tremlin et al., and they wanted to avoid the weekend oocyte retrieval. And what they did, they had about 19,642 non-programmed IVF antagonist cycles, which were analyzed to determine if advancing or delaying oocyte retrieval by 1 day from the ideal day to avoid Saturday or Sunday oocyte retrieval, respectively, had any impact on the IVF outcomes. The IVF outcomes of Tuesday to Thursday served as a control, as no modification in oocyte retrieval timing was required on these days. And what they found was that advancing the oocyte retrieval by 1 day from the ideal resulted in a small but significant decrease in the number of oocytes retrieved and embryo created. However, delaying the oocyte retrieval by 1 day from the ideal resulted in a small increase in the number of oocytes collected and embryo created. The bottom line that the deviation from the ideal day of oocyte retrieval had no significant effect on live birth rates. That's a very important thing to remember. And the authors concluded that it's possible to safely avoid weekend oocyte retrieval during gene-rich antagonist cycles by simply advancing an ideal Saturday oocyte retrieval to Friday and delaying an ideal Sunday oocyte retrieval to Monday without adversely impacting on IVF live birth outcomes. So if we conclude or summarize, Actually, I have described 4 approaches for delaying the ovum pickup in the weekends. One, initially the use of GnRH agonist, mainly the long protocol, then the use of the oral contraceptive by itself, and then the combination of oral contraceptive to GnRH agonist or either antagonist. And it seems from the literature that the combination of, or the addition of GnRH antagonist by itself with no oral contraceptive is superior upon the other protocols, and maybe in the future to come, this approach would be more adopted when we may have more results, and then we can have definitive conclusion. Thank you very much.